Hello, this is my report for patient RR, diagnosis with pneumonia related to chronic respiratory failure for nursing 442, nursing case management of vulnerable populations. Professor Judith Fidello. So patient profile. RR is a 76-year-old Caucasian male with the main diagnosis of pneumonia and chronic respiratory failure. RR's history of chronic respiratory failure occurred some years ago when he developed pneumonia of unknown cause. He developed sepsis and went into shock during his stay at the hospital. He was intubated in the ER and is now mechanically ventilator dependent. He was brought again for recurrent pneumonia to Barbara Hospital. He was previously living in the UK for 20 years with his wife. Recently, the patient decided to move to San Diego with one of his children after his wife passed away. Lack of self-care and attention to his health after the death of his wife led to declining health. Diagnosis of pneumonia occurred shortly after, leading to sepsis, resulting in chronic respiratory failure around 2015. After discharging from the hospital, RR was transferred to a subacute facility near his son's home in San Diego. His son is a busy engineer who has a wife and 2 kids of his own. Prior to admission at Vibra, reports mentioned the son visiting the patient about twice a week with his family and speaking to him regularly on the phone. The son is very involved in his care and requests to be updated with any significant findings. RR has been unable to wean off the ventilator as previously attempted by RTs and doctors. He has been on a ventilator and living in a subacute facility for the last 2 years. The patient has been readmitted multiple times for oxygen desaturation and pneumonia. During his current stay at Vibra Hospital, chest x-rays show infiltrates on bilateral lobes and positive respiratory cultures. He has been admitted to the hospital for 23 days for antibiotic therapy. He's been receiving 7.2 grams every 8 hours and vancomycin 1 gram every 8 hours IV piggyback. After 23 days of antibiotics, the patient still shows infiltrates on both lobes. The patient is currently being assessed by infectious disease doctors for unresolved and persistent infiltrates. Aside from antibiotic therapy, the patient is also receiving albuterol breathing treatments nebulizer through his tracheostomy every 6 hours and every 2 hours as needed for shortness of breath. During his stay, RR is also being repositioned every 2 hours to prevent pooling in the lungs and prevent pressure injuries. He is being seen by physical therapy for 30 minutes, 5 days a week. Because of his physical decline and respiratory condition, therapists are only able to do passive and active range of motions exercises in bed. They had previously attempted to place him on a chair, but RR became short of breath and was unable to tolerate longer than a minute. Speech therapy has also assessed his swallowing capabilities. Although he is able to tolerate the passomer valve to speak, he has repeatedly failed his swallow test. He is receiving TPN through IVP for nutrition, through IV PICC line. During RR's stay at the Vibra, acute care included antibiotic therapy, IV, chest x-rays, blood, chest x-rays and blood tests are also being performed every other day to show progress of treatment. WBCs have decreased, and since date of admission, recent x-rays have shown improvement during the last weeks. Once pneumonia has been resolved, he will be transferred back to a subacute facility. Discharge destination. Before he can be discharged, the patient has certain needs. He needs a mechanical ventilator, 24-hour respiratory monitoring, IV equipment for his TPN, nurse medication administration, and assist with all his ADLs. One of the roles of case management is discharge planning and facilitator in level of care changes. Case managers must be alert for patients' readiness to learn to change level of care, such as transfers from ICUs to a step-down unit or facility. In RR's case, the main objective is to eradicate infection and transfer patient back to a subacute facility. The method of discharge planning can be achieved by using clinical case management strategy. It involves assessing, monitoring physiological stability, planning healthcare at patient level, and using specific nursing interventions. the reason for the patient's transfer is due to infection. Rationally, the case manager has to consider a patient's health and discharge by treating until acute conditions are resolved and is able to come back to his optimal health. This is dependent on nurses for his daily care and the medical equipment to live properly. Two nursing case strategies that I use is educational and clinical. Educational, teaching a disease and treatment, coaching symptom self-management, coaching caregiving for the family. Also chose clinical nursing case manager strategy, which is assessing health, monitoring physiological stability, planning healthcare at a patient level, and using specific interventions. On a patient level, on the clinical nursing case management strategy level, the patient needs to have frequent vital sign monitoring, routine lab tests and x-rays, and antibiotic therapy regimen. Using this strategy, nurses and doctors can gauge progress through a stay. R is continually being monitored and assessed with routine lab tests and x-rays. Doctors are constantly tracking progress and making adjustments to his medications accordingly to his physiological responses. Once a patient is stable to show asymptomatic responses such as normalized WBCs, clear chest x-rays, and no evidence of respiratory distress, nurse and case management can set arrangements to transfer RR back to a subacute facility. Utilization review. For acute care management, this provides a cue to case manager to speed up a discharge plan. If the patient is doing exceptionally well, or a discharge plan, or change a discharge plan if the patient is deteriorating or remains debilitated. In RR's case, all acute symptoms have shown to be improved. He's almost back at his baseline health prior to admission. Case managers must identify high-risk complication and then institute actions for prevention. Because the patient will discharge to a subacute facility, the case management manager must be assured that all necessary equipment are available. The patient is in need of a mechanical vent with constant monitoring. He is also in need of a 24-hour care of a nurse to administer all medication and help with ADLs. Quality and safety. To avoid reactive nature of risk management activities, healthcare organizations have implemented risk mitigation programs that allow them to identify proactively potential risks or failures and to implement specific interventions to prevent these potential risks from occurring. This was highly implemented in RR's admission at the hospital as well as this subacute facility. RR's generalized weakness and lack of full mobility placed him under a fall risk program. However, hospital protocol calls for bed alarm, fall wristbands, low bed, and call light always within reach. RR's general state of health also puts him at high risk for DVTs and pressure injuries. Therefore, he's currently on anticoagulation therapy daily as well as strict repositioning every 2 hours. Lastly, due to his continuous nutrition through his PICC line, RR is on a class prevention program including routine sterile dressing changes and blood culture draws for screening weekly. Case managers routinely avert potential disasters by recognizing potential problems and resolving them before they get too far out of line. Monitoring for quality of care issues is required in all aspects of care. One of the main tenets of case management is quality care and identifying deviations from standards of care or practice is an important obligation. Patient level effectiveness. An outcome for the patient would be maximum recovery with minimal complications, careful monitoring of safe issues, normalization in labs, and no acute symptoms of distress or infection. On a system level, patient outcomes should be appropriate and efficient use of benefits and resources, care provided at the appropriate level and setting, cost-efficient care through timely use of level of care for the patient's needs, reduced length of hospital days necessary, patient and family empowerment through the participation in informed decision-making, and ensuring that the patient and family understand the direction plan of care and the knowledge of disease process through educational pathways.